Hi, everyone. Again, I'm Dr. Kirsten Rolling, and welcome to our presentation today. This is QUIT, providing a brief tobacco dependence intervention, and it's for 2 live continuing education units. Now, today we're recording this updated March the 1st, 2024. If you're watching this on our website at a later date, you're watching the recording. So you'll get your CE credit and handout by scrolling below the video player to the instructions section. Number 2 is the handout. Number 3 is the quiz. All right, conflict of interest and financial disclosure is there for you, and we are supported today by Tango Scrubs. Again, these were invented by a physician here in Arizona. They are antimicrobial scrubs. They are very comfortable, they're breathable, and they move with you. And we're going to talk about these halfway through the course. The agenda here is on the screen. Again, for those of you that are attending live today, please be in attendance here at 2 o'clock. We'll redirect you to complete a quiz for CE credit. And there are the instructions for you for the credit. All right. Dental providers are well positioned to help their patients quit tobacco, and yet very few of us feel 100% comfortable doing that. We're going to talk about why that is and why, as oral health providers, we should be concerned and we should be involved in the conversation. This is a live interactive webinar to prepare you all with the practical tools that you needed to help your patients quit tobacco. What we hope today is that you'll have skills to take back to your practice to understand what the scope of the tobacco problem is, motivate your patients to seek treatment, know how to deliver a brief tobacco dependence intervention, learn how to integrate tobacco dependence interventions within your dental practice or clinic. We're also going to talk about general tobacco information, the current data, the consequences of tobacco use, second and third hand smoke, the oral manifestations of tobacco use, and FDA-approved cessation medications. Now, like I said earlier, I'm a public health dentist here in Phoenix, Arizona. I was the chief for the Office of Oral Health for Maricopa County's Public Health Department. It's the 3rd largest public health department in the US. It was a big job. And one of the programs that I administered was a tobacco cessation training program with the Quit Lines. And we were able to send out dental hygienists across a county that's almost 10,000 square miles to various dental practices, train the trainer programs, and be able to offer continuing education live in those practices so that they learned how to communicate to their patients and how to refer their patients to the Quit Lines. So I'll be sharing some of that experience with you today. And again, for those of you who have joined live, be sure to type any questions you have for me in the chat area. Now, on a personal note, I lost both my parents to tobacco use. At a very young age, I was an adult orphan. I was orphaned because of tobacco. My parents met at Penn State when they were 18 years of age in their freshman year, and that's when they began to use tobacco products in the 1950s, when 1 in every 2 adults in the US used tobacco products, believe it or not. My mother was an English major at that time, and she was a cheerleader at Penn State. And she met my father, who was on a full college scholarship, music and engineering. He was a violinist. He was really a virtuoso. He began playing the violin when he was 4 years of age. He was really a savant. And they were both cut down early because of tobacco. My mother passed away of COPD at the age of 70. My father died of lung cancer at the age of 66. And prior to that, he had a massive heart attack. So I know that there are many of you in attendance today who have lost someone, first-degree relatives, to tobacco use, at least first degree, if not second degree. Or you have family members that are current users, right? It's very frustrating and concerning because we know about the health consequences. And then what about our patients? We're going to talk about that today. And again, if you have any questions, please be sure to type these into the chat area. So here are all the objectives on the screen. We know that tobacco dependence and nicotine addiction is the leading cause of illness and death in the United States. It's like a pandemic a year. So when we discuss tobacco, we've got to discuss the tobacco problem. Necessary to review its history, which we'll talk about, history of tobacco products, market trends, review of evidence-based strategies for tobacco cessation. The American Dental Association urges its members to become fully informed about tobacco cessation intervention techniques so that we can effectively educate our patients to, quote, overcome their addiction to tobacco. I'm not sure that anyone ever overcomes an addiction. I think they manage an addiction, right? And we'll talk about that today. Tobacco nicotine addiction is very difficult to treat and manage. And we'll also discuss those challenges as well. So Ricardo here, my grandfather smoked a pack of cigarettes a day and drank a pot of coffee every morning. He died at the age of 95 from kidney disease. And you know, there are, I can't remember the actor's name, but the same thing. So obviously genetics plays a big role as well, and our exposure as well. What else are we doing? Is that person walking every day? Are they diabetic, you know, etc.? George Burns. Thank you, Ryan. I knew it was George something, but George Burns. Yeah, the big cigars and all of that. Yeah. Okay. So the World Health Organization, May 2020, stated that tobacco kills more than 8 million globally every year. More than 7 million of those deaths are from direct tobacco use. 1.2 million are due to non-smokers being exposed to secondhand smoke. Tobacco smoking is a known risk factor for many respiratory infections. It increases the severity of respiratory diseases. And a review of studies by public health experts convened by the World Health Organization on April 29th of 2020 found that smokers are more likely to develop severe disease with COVID-19 compared to non-smokers. In March of 2020 is when I lost my first relative to COVID. I lost 4. The first one was my aunt, who had been a smoker most of her life. Her husband, my uncle, was exposed to a tremendous amount of secondhand smoke from many relatives, has survived COVID now 4 times. We'll be touching on vaping, Abby, but I also present an entire course in detail on vaping as well. Okay, so subtle tobacco industry advertising tactics hook adolescents, and this is World Health Organization again. This is Health Policy Watch, May 29th, 2020. I want to point out, when I grew up, and I'm probably older than most of you in this room, I grew up at a time where cartoons were allowed to advertise cigarettes. So every Saturday morning, that's when we were able to watch cartoons across the US. Every little child would be up early watching their black and white TV, and at some point they were colored TVs, but watching cartoons. And during those cartoons would be one after another cigarette commercials. Fred Flintstone smoking Winston cigarettes. Winston's taste good like a cigarette should. I remember those commercials. And all the parents were tucked away in bed, hoping their children weren't going to wake them up early on a Saturday morning, right? At some point, the federal government stepped in and said, whoa, tobacco industry, you're not going to advertise to our children anymore because we know you're killing people, right? So you're not going to get them hooked as children. And then other laws that we'll talk about, not selling tobacco products to minors and so forth. But let's talk about this tactic that they used, which I believe is as low as you possibly could get. In light of millions of smokers that attempted to quit smoking during the COVID-19 pandemic, the tobacco industry deployed these tactics to hook youngsters or young populations to these, quote, deadly products, according to World Health Organization experts. And what did they do? Well, they tried to promote themselves as corporate socially responsible, right? To protect their profits. Because Big Tobacco knows that time and again, we are going to have a pandemic, a respiratory pandemic that's going to wipe out millions. And certainly that was COVID-19. It continues to be wiping out folks. And so this organization started looking at the tobacco marketing that occurred at that time. Why would Big Tobacco care about the pandemic? Go ahead and type your answers into the chat area. Why would Big Tobacco care about the public in the pandemic? They would lose money, less sales, less revenue. Exactly. And in the big picture, they didn't want to lose their market share, folks. They knew that SARS-CoV-2 in the presence of a patient who smoked could kill them at a much greater rate than those that didn't smoke. So they wanted to find out how to cure this thing. And that's what they did. They invested money in vaccines, in PPE, production, and so forth. And there are a couple links for you to take a look at that. So even beyond loss of money, the big picture was that they were afraid that the pandemic would wipe out their entire market share. Those folks that used cigarettes, right? Not just cause them to stop using the product, but kill them. So they invested in various types of industries that would help support finding a cure or a vaccine for COVID-19. And here are some of those here. PPE, vaccine production, face mask production, or they'd invest in face mask companies. Hand sanitizer. Think about it. They invested in vaccines for COVID-19. So here we go, tobacco industry participation in vaccine development. And the industry invested in biotech companies, pharmaceuticals, some of which were involved in COVID-19 vaccine development. These investments were part of the tobacco industry's business strategy. Also to make them appear as they were part of the solution, representing one of the most successful corporate public relations strategies ever mounted by a tobacco company. So you can see examples in the COVID-19 monitoring database, and we'll get on with the show here. Any questions or comments before we move forward? And again, for those of you attending live, please tap on that banner at the top of the screen to download your handout, or you can access it in the chat area. I see a couple of you typing, and there's sometimes a delay, so just hang on tight there. So I'm going to show you one of these Fred Flintstone commercials from when I grew up, in case you haven't seen these. And there's a million of these on YouTube. And when I look at them, I can't even fathom that the Big Tobacco got away with this. But again, it was before we knew. This was in 1961. It was before we knew the health consequences of cigarette use. In fact, in some cases, cigarettes were promoted to pregnant women so that they wouldn't gain much weight and they'd have small babies, as if that was an advantage. So they're telling pregnant women, go ahead and smoke. All right, here's the commercial. I'm going to put the link for you in the chat area in case you can't see it. And on your device, you can watch it in a different screen.
They sure work hard, don't they, Barney?
Yeah? I hate to see them work so hard.
Yeah, me too. Let's go around back where we can't see them.
Gee, we ought to do something, Fred.
Okay? How's about taking a nap?
Hey, I got a better idea. Let's take a Winston break.
That's it! Winston is the one filter cigarette that delivers flavor 20 times a pack. Winston's got that filter blend.
Yeah, Fred. Filter blend makes the big taste difference, and only Winston has it up front where it counts. Here, ahead of the pure white filter. Winston packs rich tobaccos specially selected and specially processed for good flavor in filter smoking.
Yeah, Barney, Winston tastes good, like a cigarette should.
The Flintstones has been brought to you by Winston, America's best-selling, best-tasting filter cigarette.
Winston tastes good like a cigarette should.
So what did we do as children at that time? We'd go down to our local candy store and we'd buy candy cigarettes. They sold candy cigarettes that looked like Winston cigarettes, and we'd pretend we were smoking. They came in chocolate. They came in these horrible white chalk flavors that had like red tips on them. We were mimicking our parents and what we saw on TV. So I want you to realize that when you're treating patients right now who may be in their upper 80s, mid to upper 80s, or maybe even a little bit older, and they have COPD and they have heart disease or they have cancer, look back on what their life was like in the 1950s and 60s, because this is what they were subjected to, like my parents, right? 1 in every 2 adults in the US used tobacco products. And this was heavy stealth marketing, ridiculous marketing when we look at it now. So tobacco use is a worldwide epidemic. We call that a pandemic. And it continues to be the leading global cause of preventable death. It's the leading cause of several of the major deaths worldwide: cardiovascular disease, COPD, and lung cancer, and it's responsible for 1 in 10 deaths globally. It causes hundreds of billions of dollars of economic damage worldwide every year, and most of these countries, or most of these deaths, occur in low and middle income countries, and it's expected this gap will widen further over the next several decades, and that was prior to COVID-19. We still don't have the data on all of the patients that may have been subjected to secondhand smoke, or they tried to vape while they were concerned about using tobacco cigarettes. And we know that vaping also can lead to consequences, increased hospitalization and death when one becomes infected with SARS-CoV-2. If current trends continue over the course of the 21st century, tobacco use could kill 1 billion people or more. This was the first public health campaign against tobacco by King James VI of Scotland in 1604. And he wrote a paper, actually, that he believed that tobacco use, particularly tobacco smoking, was a custom loathsome to the eye, hateful to the nose, harmful to the brain, and dangerous to the lungs. He didn't get much press. Not too many folks agreed with him at that time. Civil War became a mass market for tobacco. The troops were given free cigarettes, for instance, and the invention of magazines and marketing led to mass campaigns using children often depicted by smoking cigars or cigarettes or pipes. And this is an example. Now we have the internet. I'm not sure how many people actually go out and buy magazines anymore, but this was pre-internet, obviously. And this allowed also for an overseas market. The invention of the match was another game changer for tobacco use, because prior to that, you had to hold your face over a lit flame. So being able to use a match made lighting cigarettes simpler, and oftentimes children, orphans that lived on the street, they were called street urchins, were used to sell matches, cigarettes, cigars, and so forth. Marketing and weight loss. This is from Stanford.edu. We know that many of the tobacco cigarette companies at the time marketed tobacco as a way for women, particularly, to lose weight. And so here's an example from Lucky Strikes. Keep a slender figure no one can deny. And then, of course, marketing and health benefits, where physicians and dentists were used in the marketing campaigns. And here was 20,679 physicians say Lucky's. And in that case, they're talking about smoother taste, not so bitter or harsh to the lungs. Here's another campaign, looks a little bit like Ronald Reagan. As your dentist, I would recommend Viceroy's. And they're marketing the filter, which we'll talk about. The American Dental Association stated in 1964 their first adopted policy or statement, then revised later on. The association should continue to educate and inform its memberships and the public about the many health hazards attributed to the use of tobacco products, particularly cigarettes, pipes, cigars, smokeless tobacco. Let's add e-cigarettes to that, or vaping now as well. This was a Viceroy ad from 1940s. And I'm going to show you another video of a ridiculous campaign that was used, where they have doctors advertising the health benefits of cigarettes. So this is one where it's a Camel cigarette. And again, this is a physician telling the public on TV that it's healthy for you to use tobacco cigarettes.
You know, if you were to follow a busy doctor as he makes his daily round of calls, you'd find yourself having a mighty busy time keeping up with him. Time out for many men of medicine usually means just long enough to enjoy a cigarette. And because they know what a pleasure it is to smoke a mild, good-tasting cigarette, they're particular about the brand they choose. In a repeated national survey, doctors in all branches of medicine, doctors in all parts of the country were asked, "What cigarette do you smoke, doctor?" Once again, the brand named most was Camel. Yes, according to this repeated nationwide survey, more doctors smoke Camels than any other cigarette. Why not change to Camels for the next 30 days and see what a difference it makes in your smoking enjoyment? See how Camels agree with your throat. See how mild and good tasting a cigarette can be.
Now, we know that women smoking at the end, and we'll look at the data. If she were alive today, she'd probably have, what, 3-4 teeth left in her head, right? Because of the periodontal disease, if she was lucky, especially those cigarettes early on. Okay, so let's go ahead and move on here. Would a gentleman offer a dental hygienist a Tiparillo? So the marketing took a turn. Why? Because while I was growing up, we had this thing called the Women's Liberation Movement, ban the bra, and so forth. And these companies started to zero in on women's independence. And, this was the early 60s, right? It was unheard of for women to go to dental school. They were zeroing in on women's occupation at that time. Dental hygiene would be one, nursing would be another, and this is one. Tiparillo was considered sort of a luxury smoke. They'd always have these sort of very sexy women on TV walking through restaurants with a silver tray, and they'd have Tiparillos on them, and they would say cigars, cigarettes, Tiparillos, and they would be offering them to some man in some very seductive way. And so here we go. They had targeted the dental hygiene community. Okay, and then Hitler banned cigarette smoking during World War II. This is thought to be the first public health effort of the 20th century. Hitler opposed smoking for Hitler reasons. He was trying to have the pure genetic race, apparently. But he ordered German scientists to study the effects of tobacco use and lung disease. Nazis were ordered to suppress tobacco use. High tobacco taxes were imposed. Hitler banned smoking in German universities, government buildings, public transportation, Nazi party offices. Restaurants were not permitted to sell tobacco products to female patrons. And after Germany surrendered, ironically, cigarettes became a surrogate currency because those left in Germany, some of my relatives, for instance, they were starving to death. So cigarettes became a surrogate currency for them. And here's some of that propaganda. All right, the German woman does not smoke, and so forth. So we're going to get on now with some data. I love data. I'm a public health dentist. I live for data. I will try not to overwhelm you with data, but let's try to make sense of some of it. For those of you that logged in a little late, make sure you have your hands on the handout by tapping on the banner at the top of the screen. Make sure you're all here in attendance at the end so that you're able to take the quiz for CE credit. All right, tobacco is a major risk factor in all of the leading causes of death except for accidents and Alzheimer's, although we'll see they are indirectly perhaps related. Nearly 500,000 tobacco-related deaths yearly, surpassing all other preventable causes of death combined. Unintentional injuries include fires. So it's estimated that cigarettes are the #1 cause of fire death in the US. Some states have mandated self-extinguishing cigarettes. So when we look at cigarettes, we're going to look at the anatomy of a cigarette here shortly. You'll see that there are burn rings. And those burn rings are chemically treated to keep the cigarette burning, whether or not someone is inhaling it or puffing on it, right? So if you fall asleep and you've lit a cigarette and it rolls off onto your sofa or your mattress, it can start a house fire. And so again, it's estimated that cigarettes are the #1 cause of fire death in the United States. Martina said her grandfather died from a house fire caused by a cigarette. I'm sorry to hear that. And that is more common than we even know. So when we look at the leading causes of death in the US and their relationship to tobacco, and this was as of 2019, and there will be more information updated. Our information was sidelined by SARS-CoV-2, but we have some more current information that we're going to share with you. These are still the same: cardiovascular disease, cancer, chronic lower respiratory disease, stroke, accidents, Alzheimer's, diabetes, influenza, pneumonia. These are the leading causes of death in the US and their relationship to tobacco as we talk. Now, this was annual global deaths, World Health Organization. This was prior to COVID, okay? It's a little hard to see. Tobacco global data, it's the single greatest preventable cause of death in the world today globally. Kills 5.4 million people a year. If left unchecked, that number will increase to more than 8 million a year by 2030. That's more than a pandemic a year. And there's the fact sheet for you. Top 5 cigarette consuming countries here. Start with China, followed by Russia, the US, Indonesia, and Japan. World cigarette consumption in the US, the Americas 11%, Europe 24%, and so forth. Cigarette smoking causes about 1 of 5 deaths in the US each year, and cigarette smoking is estimated to cause the following. So we said almost 500,000 deaths annually. That includes deaths from secondhand smoke. We have about 280,000 deaths annually among men, including deaths from secondhand smoke. 201,000 plus deaths annually among women, including secondhand smoke. Cigarette smoking causes premature death. Life expectancy for smokers is at least 10 years shorter than that for non-smokers. And if one can quit smoking before the age of 40, they'll reduce the risk of dying from smoking-related disease by about 90%. Nora wants to know, how do they know it's because of smoking and not genetic or other causes? Because they have scientists that are skilled to know how to stratify for what they're looking for. So they can remove the other elements and zero in on the death. And that's very simplistic, but that's what they do. They have economic scientists, health economy scientists, and so forth. So biostatistics is what they use. All right. Overall mortality among both male and female smokers in the US is about 3 times greater than that among similar folks who've never smoked. The major causes of excess mortality among smokers are diseases related to smoking: cancer, respiratory and vascular disease. Smokeless tobacco is a known cause of cancer. Nicotine in smokeless tobacco may increase the risk for sudden death from a condition where the heart does not beat properly, an electrical condition, electrical conduction issue with the heart, arrhythmias, ventricular arrhythmias. Over the past 100 years, global consumption has increased 100 times, and we're going to see why. But because of confluence of different factors. Marketing of tobacco, the Civil War here in the United States, as well as technology that automated the manufacturing of cigarettes. Because prior to that, prior to about 1880, you had to roll your own. But a cigarette tobacco company actually had a campaign where they advertised for someone to invent an automatic cigarette rolling machine. And a man by the name of Albert Bonsick, who invented that, won, I think it was $70,000, which was a lot of cash then. And he was able to automate, logarithmically or exponentially the manufacturing of cigarettes, so that you didn't have to roll your own, or you could purchase pre-rolled cigarettes that were hand rolled, but they were very expensive. Now they could manufacture, thousands a day and get them out into the market very quickly. So all of those things sort of came to a confluence. They developed a way to make smoother tobacco where it was adopted more readily. And they added, other chemicals and so forth to get people hooked. This is trends in cigarette smoking rates. If we look at cigarette smoking rates, they've fallen significantly since 1965, since that Fred Flintstone's commercial that I showed you. Why is that? Well, because many work practices now, you can't smoke at work or in your building when you're working. Some employers won't even insure you if you're a tobacco user, if you're using nicotine. Here at Maricopa County, annually when we renewed our health benefits, and oddly enough, in my clinic building, which was a big lockdown building, we had many nurses that smoked, and nurses have one of the professions that had the highest or greatest number of smokers, and they'd hang around the back and they'd smoke. And so the county decided that, and the county here is large, it's not just healthcare, it's not just public health, but in their benefits package, you had to be tested for nicotine use. And if you tested positive, you're going to pay more for your premium because it's going to cost more to keep you alive and treat all your illnesses that you're going to have based on your tobacco use. So everyone else shouldn't be dinged and have to pick up the slack for you. And that was the philosophy. So we had to get tested periodically, drug tested, but also for nicotine use. We've seen these rates lower here. Why? Because, again, different healthcare policies. All right, smoking rates by sex, men are significantly more likely to smoke than women. By age, when we look at this graph, I want you to see that bar 25 to 44 and then 45 to 64. And this mimics very much what we see with vaping as well, electronic cigarette use. What happens between 64 and 65? Look at this big drop off. The 65-year-olds, they're still alive, all right? Why do you see this big drop off? We have retirement here. So Avni, what's retirement going to do for them? Why would they stop smoking? Less stress. They lose insurance. Health insurance, health issues. We're getting close. They get sick, right? More doctor visits, cost, influence from others, illness, they can't afford it, they stay healthier. Okay. Death, nope, they're still alive. Okay, so you're all onto it. So what happens here? Loss of energy. They're getting close to die. Gosh, I hope not, guys. You guys are making me pretty depressed about headed towards that age. When we getting close to death. So what happens here is they don't wake up on their 65th birthday and say, hey, you know what? I'm 65 today. Today's the day I'm going to quit smoking after smoking 50 years, right? That's not what happens. What happens is they get a disease or an illness that they're physically incapable and oftentimes of picking up a cigarette. So they may have had a stroke. They may have had a lung resection because they have cancer, etc. That's what happens. So physically, and I'm going to give you an example. So my father at the age of 51 had a massive heart attack. He had a massive heart attack the Labor Day weekend before I was supposed to start dental school, by the way. I get a call, your father has had a massive heart attack. He lived in Pennsylvania. I was in California getting ready to start at UCSF. And they said, he's not going to make it. You've got to come back. I get on a red eye, fly back there with an 8-month-old infant and my husband. And he's in the ICU. He's on a balloon pump and he's on a ventilator. And he was dying. Wasn't going to make it. He had coded in the parking lot getting there to the hospital, had a massive heart attack. The doctors, knowing that I was starting dental school, and my husband said, look, we'll stay here. My husband at the time was a cardiologist. He said, he's not going to make it, Kirsten. He doesn't even know you're here. He said, go back, start your first few days, and come back. And so I ended up flying back to start dental school and flying back to Pittsburgh, back and forth. And I get a call that they're going to take your father off of life support. And, brace yourself. We don't think he's going to make it. We're going to try to get him off the ventilator. Well, he was on a balloon pump for 21 days. And when they took him off the ventilator, he survived. And they said, Mr. Rolling, we understand you're a smoker. And my father said, I understand. I quit 21 days ago. That was his sick sense of humor. And he went on to live 14 more years and died of lung cancer. But here's the thing. Many of these patients don't ever quit on their own. Many end up having an event like that where they do quit, where they end up having a massive heart attack. Certainly there are patients that don't. They'll have cancer, they'll continue to smoke. But many of them will end up where they've had an event like that and they survive it. And during that time, they quit smoking. But it was not by voluntary method, right? Some life-altering health event. Okay, so Medicare doesn't really restrict smokers, unfortunately. And COPD, they're in oxygen. So again, they develop these life-threatening illnesses that they've had a stroke, they maybe physically, or they're on oxygen or oxygen concentrator and so forth. Smoking rates by race and ethnicity. I want you to see the blue band in the middle here. This is our Alaskan Native and Native Americans with the highest smoking rate. I'm here in Arizona, so we have many Native Americans that live here. And some of them live in urban centers, and some of them live on tribally owned land. And those that are on sovereign nation or tribally owned, many of them sell cigarettes and tobacco products that are not subject to the taxation. So that's a problem, right? Because their taxes, if they were maybe more expensive and they didn't have that sort of access, may look different here. And that also mirrors vaping as well. Okay, smoking rates by education. Notice here, the higher the educational level or higher the educational attainment, the lower the smoking rate. So the converse, the less education, the greater the smoking rate. Smoking rates by income. Some of you said that the 65-year-olds, the reason why they quit smoking is they don't have as much money anymore. But what we see is the converse here. The less money that person has, the higher rate of smoking. Does that make any sense? Many of these live below the federal poverty level. So again, ratio of family income to the poverty threshold. The closer they are to living within that poverty threshold, the greater rate of smoking. Sometimes it's stress related. It is multifactorial. If you know anything or if you have any interest in knowing about root causes of health and so forth, look at some of the data out there and you will see that socioeconomic factors, we're talking about tobacco, we're talking about addiction here. Right? So they can go hand in hand. Smoking rates by sexual identity. Smoking rates are higher among gay, lesbian, or bisexual individuals of both sexes compared to straight individuals. Smoking rates by health insurance coverage. Somebody said here that they lose their insurance and so forth. Your patients who are uninsured or on Medicaid assistance have the highest rates of smoking, twice the rate as those who have private health insurance. Carla wanted to know, how did I go through that mentally in dental school? I don't remember it. You just go through it. And I had an 8-month-old and a 10-year-old at the time. So it was, I had a lot of support from the university as well, but the timing was not good. Boredom and oral fixation and addiction is extremely strong. So many of these folks that are exposed early on in life in these socioeconomically challenged environments, if this is all they know, this is what they inherit. Smoking rates by urban versus rural. We'll see that rural has a slightly greater smoking rate than urban residents. Dual use. If somebody asking about vaping, we'll talk about vaping in a little bit more detail. Again, I present a 1-hour course on vaping, every month, just about, or I think every quarter now. You can go to the website and it's available on demand. Dual use of cigarettes and electronic cigarettes by adults. What I want you to know here, and you don't have to memorize all of this, is understand your patients that come in vaping are probably using both. Almost 80% of those are using both. They're dual users. They're using both electronic cigarettes, vaping, and tobacco cigarettes. Why? Because they got duped into thinking that electronic cigarettes would help them quit smoking. And so they're getting much more nicotine. In fact, we know that some of the disposable electronic cigarettes have as much nicotine, one of them, as an entire pack of tobacco cigarettes. Also, I noticed a behavioral difference with vapors. And I was visiting my family in Pennsylvania over last summer, and the majority of my family are blue-collar workers. We have those of us that escaped Pennsylvania in the first recession and went on to California. We got out and we were able to get education, and but we go back for our reunions and we love our family, and they have a different lifestyle. They all smoke, they all vape. And they're walking around the reunion with these devices like they're pacifiers. They're in their hands all the time. And cigarettes are a little different, right? You don't see someone using the cigarettes not in their hand all the time. It might be lit and they may have an ash, but they're walking around with these vapes all the time, and they're standing there just like they're sipping on a big gulp. And to me, they're getting much more nicotine, I think, than we even realize, right? They're getting much more nicotine. And it's associated around different activities. It's socialization. So take the class. We talk about that. I know Mount Washington well. So among current users of e-cigarettes, 41% also currently use tobacco products. 38% were former smokers. So here's what you need to know. Current electronic cigarette users, as we said, are probably current tobacco cigarette users. And those who are not using tobacco cigarettes are probably non-smokers or those who quit over a year ago. Current vapors tried to quit smoking within the last year and they failed, and they may have failed multiple times. So when you're talking about tobacco to your patients, we want to talk about vaping most definitely, and other non-tobacco devices as well that deliver nicotine. All right, so we said that nearly 500,000 Americans die every year due to tobacco. That's about 20%, 1 in 5 deaths. $300 billion a year are thought to be attributed to smoking. We see that the cost is in the billions of dollars for direct medical care of adults. And we also have to talk about loss of productivity because of premature deaths. In the case of my parents, it took out a nurse and it took out an engineer and a brilliant violinist way, way, way early. $35 per pack related healthcare cost. I'm guessing that's probably more now since COVID. I don't have that number in front of me, but suffice to say it's probably ugly, right? I know in the case of my mother with COPD again is chronic obstructive pulmonary disease. There's nothing chronic about COPD. Those that suffer from COPD die a slow death from suffocation. A slow death from suffocation. And her hospital bills, she was hospitalized over 50 times over 3 years. In and out of the hospital, 50 times. Her medical bills, just one of those medical bills, exceeded $200,000. So I'm not surprised by that at all. And she was somebody that tried to quit smoking. She was a psychiatric nurse. She worked in a locked unit, loved her patients. Part of her job was to take her patients outside to smoke because many of them, as we'll see, behavioral health patients are smokers. It's part of her job. So she was subjected also to quite a bit of secondhand smoke. We said in the mid-1960s, 50% of Americans smoked, more men than women. The Surgeon General report in 1965. So the Surgeon General report came out and said, hey, folks, We think that tobacco causes lung disease and heart disease and some other things. And we think that cigarettes need to be banned. Well, it took years, and it took unearthing the lies of the big tobacco companies in front of Congress to come up with laws. But those laws that were cut were deals with lobbyists, because tobacco is a big industry in the US, as we'll see. So for the first time in the US now, we see more former smokers than we do current smokers. So when we look at this graph, what we see here, more men more likely to be current cigarette smokers than women. Nearly 16 of every 100 adult men, about 12 of every adult women. And we see a decline. And there's 1965. That was around the time of the Fred Flintstone video. The blue dotted line is men. The red solid line are women. Number of cigarettes per day has changed significantly due to what? Workplace bans, as I said, and smoking restrictions. You can't smoke. In some states, you can't even smoke in a car with a child in the car with you, right? Gosh only knows how much nicotine or tobacco I was exposed to growing up. We're in the station wagon, both parents smoking in the winter in Pennsylvania, or in the house, right? We were always sick. I had pneumonia twice. I had a brother with bronchial asthma. It's no wonder. No more smoking on planes. Yeah, I remember that too. All right. This is a comparison here of intermittent, daily, light, and heavy smokers, and also according to race. There's different behavioral types of smoking. Some are they take a long draw. Some of them will take short, heavy puffs to get as much nicotine as they possibly can. Some smoke more on the weekends. You've had these patients. You ask them about their tobacco use, and they say, "Oh, doc, I just smoke on the weekends. I have a couple of cigarettes with my friends. We go out and have a drink or whatever, and that's it." Well, they're still addicted. We'll talk about that. They don't think they're addicted. When they go to try to stop and they have withdrawal, they're not able to connect those withdrawal. The withdrawal can be delayed, their symptoms. So they don't make the connection that what they're experiencing is nicotine withdrawal. All right, so daily light smokers are likely to express less concern about tobacco addiction. Okay, nearly 2/3 of the world's smokers live in 10 countries. Here they are. There's the breakdown for you. And then cigarette smoking is down, but about 34 million American adults still smoke. What do we know about certain groups in cigarette smoking? Here are the high-risk groups or higher risk groups. Men, adults 25 to 64, as we said. Lower education. The lower the education, the higher the rate of smoking. Those that live below the poverty level have a higher prevalence of smoking. Those that live rurally, in this case, Midwest and South. The uninsured or Medicaid patients, more likely to smoke. The disabled, which we have not got into yet. Those with mental health disorders or behavioral health disorders have a higher rate of smoking. We'll see almost half those deaths that we talked about have behavioral health or psychological mental health issues. Alaskan Native and Native Americans, and then lesbian, gays, and bisexuals. Okay, this is a good place to stop for the break. I'm going to present information from our sponsor here. It is not required for CE credit. It's going to take about 15 minutes. These are Tango scrubs. They're antimicrobial scrubs that I'm going to talk to you about. And before I do that, let me see if anyone has any questions. want to remind you too, cigar category. So what is cigar categorized as? It's a tobacco product. We'll talk about that after the break as well. Many of your cigar users believe that they're safe because they don't inhale, but we find out they're just as harmful. If you do experience any issues with audio or video, it will be on your end unless we make an announcement about it. All right, so you can log out, log back in. That may help because your broadband might not be stable, or if you're moving. All right, you won't get dinged for that, and make sure you're using Chrome browser. All right, so these are Tango scrubs, and these were invented by Dr. Yaz here in Arizona. He is a medical doctor. He's a physician. He's actually a hospitalist. And he saw a need for antimicrobial scrubs that looked stylish, but also moved with you, that they were breathable. He works long hours in a hospital, and he designed these. And if you can, and we're not done yet, we're going to be picking up the next hour of our presentation. So please be sure that you're here to the end. This is, again, promotional, not required, so you can take a few minutes if you'd like. Dr. Yaz is going to offer to you all a discount for trying them. He's just launched these. He wants to get them out to the dental practices as well. As many of you know, I teach infection control, and we are really lacking decent, nice antimicrobial scrubs. Why do we need antimicrobial scrubs? Because we're immersed in aerosol all the time, and we are subject to working in a contaminated environment. All right, so again, we'll talk about what this promo code here is in a minute, so be sure to stay on. So Tango scrubs, invented here by I call him Dr. Yaz Abdelkader, and he invented a revolutionary dental attire designed for comfort and style, but also safety, antimicrobial, right? The scrubs are crafted with excellent materials. They're very high quality to provide durability and performance, and they are able to offer bulk pricing. So if you have a DSO or a clinic, reach out to us or to Dr. Yaz, and he will be happy to get back to you with a proposal for you. They can also be embroidered as well. The benefits here: comfort, flexibility, antimicrobial, innovative design, ease of movement, all-day comfort. Again, it's antimicrobial, it's moisture wicking, it moves with you, it's very flexible, and a clean and fresh feel throughout the day. So again, in dentistry, we are always concerned about the aerosol. Of course, we're going to use disposable gowns, but you take those gowns off, you're still working in an environment that is immersed in aerosol. Okay. Different customer testimonials, and we have some dentists here as well, Dr. Gombert here. So again, the fit is really nice, they're stylish, but the benefit of being antimicrobial is great. And if you've had any familiarity with antimicrobial scrubs, usually they're stiff, they're not pretty or stylish looking at all, they don't move with you, and they don't breathe, and these do. So he's put a lot of time and thought and research into designing these. Okay, he's going to offer to you a promo code here, Take 10 Now, and you can enter that. And I believe they have other promotions on their website as well. So if you are interested in ordering, if you need information about sizing, it is on the website also. And again, there's the information. Any questions for me? Kelly, I believe there is a catalog. It's online. And this presentation's in your handout as well, and you can reach out to their sales team. Okay. So again, reach out to Dr. Yaz. Any questions about these? I've had familiarity with antimicrobial scrubs in the past, and again, I think my big concern with them was that they were scratchy, they were stiff, they were ugly, and the quality wasn't there. And these are, again, very high quality, very stylish. So if you need any embroidery or you need bulk pricing, reach out to them. In terms of what's in the garment, Nora, reach out to them and they will give you a breakdown. But the feel there, it's soft, very soft fabric, and it bends with you. They're great. And when he reached out to me, he was talking about, what do we need in dentistry and so forth. And it's exactly this. And he wanted you all to know that he is a medical doctor, but he's very interested in knowing how he can help the dental community. Yeah, the look is nice. Okay, so this handout is in your course folder. And if you tap on the banner at the top of the screen, you can bookmark the website. It's tangoscrubs.com. Save it to your device. Send them an email, let them know that you saw it on the website and that are on our platform, and they'll send you more information. And definitely use the promo code here. So, and if you have any further questions about sizing or pricing or anything like that, let them know. And he's coming out with more styles as well. But if you're looking for performance, high quality, safety, etc., these are great. And he really came out starting to produce these for hospitals and the medical side. And then we had a conversation and I said, listen, this is really needed in dentistry. And my focus is infection control. And this is something I'll be talking about tomorrow during our infection control program is your scrubs. Because if you are wearing your scrubs from home to work and vice versa, you've raised the concern about cross-contamination. So you want a way to be able to protect yourselves and be able to protect your family members at home. I had a C. difficile infection. C. difficile is caused by contamination in the medical environment and so forth. So you want to have something that's going to be safe for you. The collars are great, and these are great scrubs. So thank you, everyone, for staying here and listening. And I'll leave this up for just a couple more minutes, and then we'll resume here at 2:15. In the meantime, if you have any questions for me about the class or these, let me know, and you can type into the chat area. Okay. Again, one more time, if you want to save that link, just tap on the banner at the top of the screen. You can save it to your device and reach out to Dr. Yaz and let them know that you saw the information on Dental CE Academy. If you need bulk pricing, he said he's able to work with you on that. If you need embroidery, they can give you quotes. Or you can take a screenshot it too. Perfect. All right. Well, thank you, everyone. And I congratulate Dr. Yaz on a great invention. I think it's great. It's well needed. And I also want to thank them for presenting or sponsoring our presentation today. So we have a couple of questions before the presentation ended. I'll be taking a look at here as we get back from the break. Thanks, Irma. I appreciate that. The live class tomorrow. So I'm always adding information, Dana, but if you took the on-demand course, I think we recorded that one fairly recently, so the information is probably similar. But if you need live units, it's available tomorrow. Our infection control course is offered live twice every month on Saturdays. So I'll be back at it tomorrow morning from 8 to 11:30 here from Phoenix, Arizona. And that's Pacific time, by the way. So it's a very comprehensive course. Because I've had to inspect dental practices, I'm sharing information that I've seen. It's practical knowledge that you can take back on Monday and immediately implement and raise the safety in your dental practice, right? I'm not so worried about every CDC recommendation, although we cover that. What I'm going to give you is real life scenarios that you can take back to your practice and implement. Okay? All right, I'm going to put the handout back up there because I know some of you will need it. Any questions from before the break? So I'm going to put the handout back up. And again, I hope you'll reach out to Tango Scrubs because I love supporting clinicians that invent something. Every technology on our website right now that supports our program was invented by a dentist, and now we have a physician. Every technology, oral rinses, medical devices, lasers, and everything, all invented by dentists, and now we have a physician that's joined us as well. So I'm super excited about that. And to be able to offer something that you can improve the safety in your dental practice. Okay, so that handout link should work for you all. There it is, it's back. And let's go ahead and move forward here. We're going to talk now about the health consequences of tobacco use. Let me go in and see what questions we have. Melissa wants to know, what is the secondhand smoke impact with e-cigarettes? The school bathrooms always have kids using e-cigarettes. So we have to be worried about secondhand and thirdhand, as you'll see, even with tobacco. With vaping, if you smell the vape, you're inhaling the vapor, which is really aerosol. And so you're inhaling nicotine. You're inhaling whatever delivery agent they're using, any flavorings that have been added, which also can impact lung health. So, and over the long run, users are subjected to more formaldehyde releasing agents than those that use traditional tobacco cigarettes, the gaseous formaldehyde. So the thought here is that perhaps regular vape users on a first-hand basis can increase their cancer risk for maybe up to 15 times that of traditional tobacco cigarettes, because those formaldehyde releasing agents can embed very deeply into the respiratory tract, right? So we don't even have a handle on that yet. And it's a very complicated industry. So again, we talk about that for 1 hour during the vaping course, and it's available to you on demand. Okay. I think I'm at the end here. People that smoke and live around environmental hazards such as volcanoes are more susceptible in developing lung disease. Correct. So here in the Southwest, for instance, we have ozone issues. We have ozone alerts. And if you're a smoker and you're living in an ozone area, the same. If you are a smoker and you live in an area where there's a lot of other smoke, wildfires, smoke from wood burning stoves or fireplaces also increases your risk. The additive menthol we'll talk about as well. Okay, health consequences of tobacco use. Tobacco effects specific to women, children, and infants. We know that nicotine addiction is considered now a pediatric disease. This is a policy statement by the American Academy of Pediatrics. In 2006, which was 18 years ago, 3 million young people, 12 to 17 years of age, used tobacco cigarettes. 3,000 became regular users every day, and 1/3 of those will eventually die from a tobacco-related disease. What about adolescents and tobacco use? Evidence indicates that young people can become addicted or tobacco dependent in just weeks of initiation. The brains are not fully mature. We know brain maturity continues on well past preteen and teen days. And so those brains are still developing. And the CDC reports that every day more than 3,200 persons under the age of 18 smoke their first cigarette. An estimated 2,100 youth and young adults who have been occasional smokers will now become daily cigarette smokers. And the 50th anniversary of the Surgeon General's report on smoking and health estimated that 5.6 million of today's children will ultimately die early from smoking if we do not do more to reduce current smoking trends. Women in smoking. So I don't know how many of you out there were from this time. I certainly was. I don't know if this caused me to be a dentist or not. I wanted to be a veterinarian at first, but I had a litter of kittens die and I decided I didn't have the heart for it. So I became a dentist. These commercials were targeting women at a time, the feminist movement, the women's liberation movement, ban the bra, etc. These were Virginia Slim commercials. You've come a long way, baby. Now, I'm going to demonstrate to you how stealth and how effective this marketing was on children. Okay, this was 1971. I was a little girl, but I remember these commercials. And here's the tagline. So I want you to think about the fact that I was in school full-time 10 years in dentistry and research, how much I have stored in my head. And I remember this. You've come a long way, baby, to get where you've got to today. You've got your own cigarette now, baby. You've come a long, long way. How hypnotized was I growing up to hear that as a little girl, and I can remember it all these years later. And imagine how many little girls turned into women using Virginia Slims who aren't with us anymore because they bought into the hype, right? So here we have a woman in a Wonder Woman suit, and we make Virginia Slims especially for women because they are biologically superior to men. So they were trying to elevate women into believing that their status would be improved if they were smoking cigarettes like the men and others. Laura remembers the ad word for word. Unique health risks to women smokers. So unfortunately, that was not the case. Virginia Slims lied. Adverse health effects during pregnancy, increased risk of cervical cancer, reduced fertility, increased risk of coronary heart disease, of smoking and taking oral contraceptives, earlier natural menopause, lower bone density post-menopause. Women in smoking continued. 250 million women in the world are daily smokers, and 22% in developed countries, 9% in developing countries smoke tobacco. And as we said, 2013, about 15.3% of women smoked. Smoking rates for female adolescents have declined while rising in the 25 to 44 and 44 to 65-year-old age group. However, vaping is changing those numbers. Since 1980, 3 million women died due to smoking-related illness. Since 1987, lung cancer has killed more women than breast cancer. And 30% of high school girls report smoking in the past month. Increased risk for death among women. Women who smoke increase the risk of dying from bronchitis, emphysema, and emphysema by 12 times, from cancer of the trachea, lung, and bronchus by more than 12 times. Between 1960 and 1990, deaths from lung cancer among women increased by more than 500%. In 1987, lung cancer surpassed breast cancer to become the leading cause of cancer death among U.S. women. In 2000, 67,600 women died from lung cancer. And from 2010 to 14, almost 282,000 women, that's 56,359 women yearly, will die from lung cancer. Smoking increases the risk from dying from coronary heart disease among middle-aged women by almost 5 times. Increased risk for death among men. Men who smoke increase the risk of dying from bronchitis and emphysema by about 17 times, from cancer of the trachea, lung, and bronchus by more than 23 times. Smoking increases the risk of dying from coronary heart disease among middle-aged men by almost 4 times. Comment here from Carlimi. There should be stronger laws and on infection control in the dental office, holding everyone accountable from top owners to front desk, treatment coordinator, assistant. I see and go through horror situations, and I try to inform. However, when the one on the top doesn't care, is too cheap, that attitude trickles down to the staff. It's exhausting and heartbreaking. So we talk about that at great depth tomorrow during our infection control course. And I could not agree with you more. That's a great statement. I know there are a lot of practices out there that have really exceeded what's required, and they don't get enough credit for what they're doing either. Let's talk now about anatomy of a cigarette. So when we look at a cigarette, we're looking at a paper tube. It's filled with tobacco that's been treated with various chemicals called reconstituted tobacco. We spoke about the burn rings earlier. We also had a new addition here. This is the filter. And the filter was designed to market to users and potential users to try to improve safety of the cigarette, or allude to preventing or allude to improving safety, right? We know that the filter is just a marketing hype. It doesn't really work. Now, the tobacco inside of the cigarette is made up of about 600 different chemical additives: ammonia to enhance absorption, chocolate to mask the bitter taste. The puffed or expanded tobacco is freeze-dried, also found in cigarettes. We talked about the chemical burn rings that are there to keep that cigarette burning, even when someone is not puffing on it, which has contributed to house fires. The filter was introduced in 1954 because of the possibility of a link between lung cancer and heart disease and cigarette use, right? It was really a marketing hype, and it was marketed supposedly to, again, protect the consumer from these potential hazards. However, we don't have evidence that filters reduce the risk of smoking. In fact, users will typically put their lips around the holes in those filters. They're titrating their own nicotine, so they're trying to get more of a draw. And the testing is not accurate because the tests that they use don't have lips. Or some users will put their fingers over the filter. Chemicals found in cigarettes, 600 different. When burned, they create more than 4,800 compounds and 11 human carcinogens. Now, some of these chemicals that are in tobacco are not even required, or in tobacco are required to be published on other consumer products as a hazard, poisons, etc. Arsenic, butane, cadmium. But tobacco industry, because of the lobbyists, have been able to remove those sorts of warnings on the cigarettes, right? Understand also, nicotine is a psychoactive drug. That is the part that keeps people hooked. And we'll talk about that in a few minutes here. So see, these are some of the toxins in the cigarettes. Monica wants to know if I ever smoked. I've never smoked. I have never picked up a cigarette in my life. But I'm sure that I was exposed to quite a bit of secondhand smoke. And the other reason why I didn't ever smoke was that my grandmother died while I was in her home. She was 65 from emphysema. And she never smoked either, but she lived with my grandfather, who was a horrible Camel smoker. He was a professional bowler, and he smoked like a chimney. And she developed emphysema. Well, of course, they lived in the same home. And she, I think, probably had RSV or something one winter and died while I was there. I was sitting there bedside when she died. And I told myself I would never, ever, ever smoke a cigarette, would never do it. But my siblings all smoked. And even when my father died of lung cancer, and even when he was at the funeral home allowed smoking. This was in Pittsburgh, Pennsylvania. You could smoke in the funeral home. And when I got there, I was so offended by the whole thing that I took the ashtrays away and I threw them in their dumpster. And I told everybody there, you're not going to smoke in front of my father's dead body here today, because we're going to honor and respect him and have respect for an illness that could potentially kill all of you. One of those happened to be a brother. I have 3 brothers. They all smoked. Well, 2 of them quit smoking immediately and 1 did not. And the brother who did not quit smoking, who's in Pittsburgh, who will remain unnamed, had a massive heart attack 2 years ago. He's younger than me, young, massive heart attack, coded, and was quite ill and now has recovered and he quit smoking. But this is how it works, right? It's a horrible thing to watch, and it's an addiction. So it's not a bad habit that somebody can just break. It's an addiction, and these folks need a lot of help, which is why we're here today. We're going to talk about how we can help our patients. Nicotine is a potent parasympathomimetic alkaloid. All right. What does it mean? It's produced in the nightshade family of plants. It's produced in the roots. It's a stimulant, and it is stored in the leaves. So evolution created this situation where the leaves, once the nicotine was stored in the leaves, it would help that plant not be eaten up by insects and birds, right? It's a poison. And it's an anti-herbivore. So it was used on crops as well, used as an insecticide. Safety of electronic cigarettes. We had someone ask about e-cigarettes. So this is a brief overview because this is a lot of material. I do offer 1 hour class on electronic cigarettes, the culture of vaping. You'll see it available on demand as well as live about once a quarter. So in terms of e-cigarettes, the FDA has not determined that electronic cigarettes are safe or that they're effective in helping someone quit smoking. Now, we have to say and preface that there is a brand out there that was approved, that they're able to market, that it can help patients quit smoking, but it is not an FDA-approved drug. And that's the difference. Many e-cigarette users continue to use e-cigarettes. As we said, they're dual users. And we know that even smoking a few cigarettes a day is dangerous to your health. There are 7 FDA-approved drugs to help smokers quit. E-cigarettes are not approved as an FDA-approved drug. We know that e-cigarette use among children tripled, for instance, early on from 2011 to 2013. Why? Aggressive marketing tactics, flavorings, cotton candy, gummy bears, Fruit Loops, etc. Those were flavors marketed for children, not for adults. So aggressive marketing. They were able to market these, and they continue to, because they had labeled them early on as non-tobacco products. The laws have changed, and we talk about that now in the class, which is really beyond the scope of this course. Smokeless tobacco here, not safe, contains 28 carcinogens. The amount of nicotine absorbed from smokeless tobacco can be 3 to 4 times that of a traditional tobacco cigarette. This is snuff, so they look like little tea pouches. Users can use them while they're at work, keep them up under their lip, throw them away very discreetly. Health risk of smokeless tobacco. Well, long-term use, greater risk of heart attack and stroke, increased risk for various cancers, oral, esophageal, pancreatic, increases oral inflammation of the mucosa, periodontal disease, dental caries. High levels of nicotine and nitrosamines are the major contributors to the health effects associated with the use of smokeless tobacco. Roll your owns and dissolvables. So roll your owns, when tobacco taxes were imposed by states to help reduce the use, they thought if they could raise the price, that it might put it out of the price range of the user, and it has helped in some ways. And the tobacco use tax is used for various programs in public health, for instance. Roll your own. So folks will go and buy the paper, they'll buy the tobacco, and they'll roll their own cigarette. Dissolvables are another way that somebody can absorb a candy-like either a lozenge, an orb, or like a toothpick stick that contains nicotine. Oftentimes they are flavored, or they'll look like melt-away strips. Effects and smoking and tobacco use. I always remember they use in health class. In high school, you'd see the black lung that they'd pass around in the jar. 90% of my people in my class when I was in high school were already smoking. We had a smoking lounge in our high school for seniors. This was the 70s. You were allowed to smoke in high school if you were a senior. Crazy. Effects of smoking and tobacco use. We'll go ahead and get on with it here. Atherosclerosis is increased, so hardening of the blood vessels. Platelets can become sticky, so increased risk for blood clot. Chronic inflammation of the endothelium. It makes the arteries, the vessels, stiff. So overall, what happens here is that the heart becomes robbed of oxygen. Now, it also has an effect on blood cholesterol. It lowers the good cholesterol and it raises the bad LDL cholesterol. Effects on respiratory system. Initially an irritant to the lung tissue, so that can be reversed if somebody quits right away. But over time, it can be a permanent condition. It's progressive tissue destruction. Fibrosis occurs. The lungs are no longer elastic. Emphysema, 90% of the cases are due to smoking, chronic bronchitis, asthma, and COPD. Third leading cause of death. 85 to 90% of the cases of COPD are due to smoking. Women who smoked are 13 times more likely to die from COPD than those who have never smoked. Lung cancer, 27% of all cancer deaths, the leading cause of all cancer deaths, and 13% of cancer diagnosed, and we said surpassed breast cancer in women in the 1980s. Oral health and effects in the oral cavity, you've seen it. Staining, periodontal inflammation, and what? Tooth loss. Many of your patients know that smoking is bad for their lungs. It's bad for their heart. But if you tell them that they're going to lose their teeth, in some of them, the bell goes off. They don't want to lose their teeth. And that can be a motivating factor. And that can be the first time they may have ever heard that. And they're in your chair and you know they have periodontal disease or other issues. They're there for a reason. Usually it's connected to their tobacco use. So that is sort of the learning moment, if you will. If your patients come into you, you can use that as a time to have a discussion about the tobacco use and the fact that they are at an increased risk for losing their teeth. Effects on the oral cavity, periodontal disease, 50% of the cases are linked to smoking. Of course, staining, oral pharyngeal cancer, 75% of oral cancers are linked to tobacco use. 6 times the risk for oral cancer. Oral cancer occurs 2 to 1 male to female. 40 years ago, that was 5 to 1. So women are catching up now. Cigar smoking can cause oral cancer without inhaling. We had someone ask about cigars. Tooth loss is 2 to 3 times greater in smokers. So again, have that conversation with your patient and we'll talk about that. Not fear mongering. I'm very matter of fact, and I've practiced in public health clinics for 30 years. And I have a matter of fact conversation with the patient. I let them know I have a duty to let you know that if you continue using tobacco products, there's a chance that you could lose all of your teeth. So what can we do today to help you so that doesn't happen? Smokeless tobacco causes gingival recession, we know, white lesions, combined with excessive alcohol use, the cocktail for developing oral cancer. Associated with chronic bad breath, loss of taste, in some cases xerostomia or salivary changes, higher risk of cardiac respiratory complications post-operatively, higher risk of post-operative infection. So let me ask you all, when you have a patient that comes in that you know you're going to need to extract a tooth on and they're a smoker, what do you tell them? Post-operatively, what are your instructions? Go ahead and type them in the chat area. Delay healing. Don't smoke. No smoking or spitting. Okay, you might not heal properly. You might develop a dry socket. Right, all of it. All right, so knowing that nicotine use is highly addictive, it's an addiction. And we're telling our patients to stop using their drug of choice for 2 days. Is that a realistic request? Probably not. I don't think we can tell an addict to stop doing something for 2 or 3 days. They're not able to do it. They need help. So it's not realistic. And so oftentimes they have infection post-operatively, dry sockets, etc. If you know anything about photobiomodulation, cold laser or low-level laser, those devices, and some of them are take-home devices, are excellent to help prevent dry sockets in your smokers. We know in medicine, they're more likely to be admitted to the ICU. Post-operatively, there's an increased risk of death while they're in the hospital post-operatively, and they're hospitalized longer. So we know that this is complicated, and smoking does cause these post-operative complications, and we're certainly concerned about their post-operative healing and so forth. Smoking and behavioral health, tobacco use 2 to 4 times higher in populations with mental health disorder. 44% of cigarettes consumed are by those with mental illness and or other addictions. And of the nearly 500,000 annual deaths, 200,000 that occur among those who are mentally ill and or afflicted with substance abuse disorders. Smoking cessation is associated with greater abstinence from drug use after completion of drug abuse treatment without any adverse effects on psychiatric symptoms. So it used to be if somebody went into drug rehab program and they were still a tobacco smoker, they would leave a tobacco smoker. So now it's required that they stop everything, because the experts know if they remove tobacco, nicotine addiction from their whole addiction spectrum here, it's going to improve their rate of success, right? So having them leave being addicted to cigarettes or tobacco is not beneficial. Secondhand smoke. It's called environmental tobacco smoke. It's a class A carcinogen. It's a health hazard for all, causing more than 41,000 deaths each year, and almost 60% of U.S. children aged 3 to 11. That's 22 million children in the U.S. are exposed to secondhand smoke. Exposure of children to secondhand smoke increases asthma, pneumonia, and croup by 60%, can increase the risk for middle ear infection, the major cause of sudden infant death syndrome, and it induces asthma in asymptomatic children. But for many of your patients, they may not realize if they are exposing their children to secondhand smoke, it can increase the risk of dental decay in their children. And here's a study. This was reported by the American Dental Association in 2015 that infants exposed to secondhand smoke at 4 months of age seem more likely to develop caries by 3 years of age. And this is because the exposure causes a form of xerostomia. So an enzyme that would normally be protective for dental decay is affected. And so in that case, they have a lower salivary IgA level, higher levels of sialic acid with higher activity. And sialic acid enhances the agglutination of mutans streptococci, makes it stickier, right? So it leads to the formation of dental plaque and caries. So let your patients know. Secondhand smoke and effect on non-smokers. We know that for women that are living with a smoker, they have a greater risk of stroke. For instance, increased heart risk by 25 to 30% for non-smokers, and lung cancer risk by 20 to 30%. Third-hand smoke. So third-hand smoke is what would be left on the walls, flooring, inside vehicles, and so forth. It's a hazard too. There's no safe level of exposure to tobacco smoke. It can affect the resale rate of vehicles and houses because it's considered a risk. That's carcinogens that will remain in the floor and the walls. Facts about quitting smoking. Mark Twain said, quitting smoking is easy. I've done it 1,000 times, right? Your patients are going to say to you, you know, I'm a failure. I can't quit smoking. I've tried so many times. It's not been, I've not been successful. It's hopeless. And my brother used to say that until he had a massive heart attack 2 years ago and almost died. So nicotine, first of all, as we said, is a psychoaddictive drug. This is what keeps the user drawn into the addiction, right? And then social activities. They will link smoking with other social activities, eating, being out with their friends, talking on the phone, driving in the car. It makes an extremely difficult addiction to break. And it's been said cigarettes are the most efficient drug delivery system. Nicotine will be delivered to the brain within a minute. This was a study in 2013 that said they suggest that behavioral interventions for tobacco cessation conducted by oral health professionals incorporated with an oral examination in the dental office may increase tobacco abstinence rates among both cigarette smokers and smokeless tobacco users. Now, the American Medical Association believes that tobacco addiction should be considered a primary disease state. So when somebody is admitted to the hospital for a heart attack, you know, myocardial infarction, COPD, and they're a smoker, their primary diagnosis is tobacco use disorder, and the myocardial infarction is a secondary disease state. So again, tobacco addiction is considered their primary disease state. And they will oftentimes start tobacco cessation while that patient is in the hospital. But in dentistry, we sometimes will look at conditions like periodontal disease, and we will schedule that patient who's a smoker for 4 quads of scaling and root planing. When, let's face it, we all know that the prognosis for a patient who's smoking a pack a day with quadrant scaling root planing is poor, right? Guarded prognosis. So maybe we need to rethink how we're diagnosing these various oral health diseases and conditions in smokers. Maybe tobacco use needs to be their primary diagnosis, and periodontal disease may need to be the secondary diagnosis. And of course, the patient should be informed that unless they quit smoking, the quadrant scaling root planing is not going to be the end all for them, right? We know that. Multiple quit attempts are very common in these patients, and they're going to again tell you, I've tried. But we know the further along they are, if they've tried to quit multiple times, the greater the chance that there is hope for them in the future. And we have to let them know that. 7 medications approved by the FDA for tobacco cessation: nicotine patches, gum, and lozenges, which are available over the counter. Nicotine nasal spray and inhaler are by prescription only. And then non-nicotine pills, Zyban and Chantix. Short term here, benefits of quitting smoking: lowered blood pressure, increased peripheral circulation, carbon monoxide levels will drop, improved smell and taste, cilia regrowth, decreased mucus viscosity, increased lung function, and diminished fatigue. Long-term benefits: risk of cardiovascular disease is that of a non-smoker. Precancerous cells are replaced. The risk of various cancers will decrease depending on the type of cancer, but the risk of lung cancer remains. It decreases by 30 to 50%. After 20 years, that reduction is greater. And that's why we really need to be able to reach our young people, because we can save them. Tobacco dependence is complex. It's the biopsychosocial model that we're talking about here: biological, psychological, and social. So these factors have to all be considered during a quit attempt. More than 70% want to stop, 46% try each year. Most quitters were going to relapse within just a few days. 75 to 80% are going to relapse within 6 months, and 3 to 5% of smokers will achieve freedom from tobacco yearly. So you have patients that may be the best thing we can hope for is long-term remission. They may go from long-term remission back to smoking and back again. That is common with an addiction. Doesn't mean they're a failure. It's part of the illness. Okay? Understand that 3 to 5% at the end of the year will continue to be a former smoker. So if you have a patient in your chair on Monday who tells you, "I quit smoking last month," chances are by the next time they come back for a recare appointment, they're no longer going to be a former smoker. They're going to be a current smoker again. The odds are stacked against them, which is why we need to refer them to a professional. Okay, 80% of smokers start before the age of 18. Symptoms of dependence occur within the first few cigarettes. Many adolescent smokers will describe themselves as dependent. And for occasional smokers, as we said, withdrawal symptoms can take days to appear. The biological cause is the nicotine. Nicotine takes 7 seconds to reach the brain. And biology tendency for our bodies is to maintain homeostasis. So therefore, patients will experience cravings as they try to quit. And those cravings have to be addressed. And oftentimes they're addressed through medication. Tobacco withdrawal symptoms: irritability, anxiety, difficulty concentrating, increased appetite, weight gain, restlessness, depressed mood, insomnia. Our role in impacting tobacco use: of course, training programs like these that are used to encourage health professionals to ask their patients if they smoke and offer advice to help them quit. And these were studies that showed that these programs work. We spoke of the 7 first-line medications. Notice we don't see electronic cigarettes there. Model for treatment of tobacco use and dependence: it used to be ask, advise, assess, assist, and arrange for follow-up. This was a complex model, very difficult to implement in a dental practice. Dental practices are busy places. We don't really have a place to counsel our patients for tobacco use. And you know what? We're not really that good at it because there are professionals out there that are much better at it than us. We need to be a conduit to get these patients identified, establish rapport with them, and get them referred to professionals. And when we establish rapport, it's a caring model. We're trying to help them. We're not nagging them. We're letting them know, hey, you're here because of an oral health matter, and that oral health matter is connected to your tobacco use. So instead, we can use the 2 A's and R. We ask every patient about their tobacco use, their electronic cigarette use. And it's not enough just to have them check it off on a form. Do you currently smoke or use any tobacco products or vape? they say yes, we're going to advise them to quit. The best thing you can do today for your overall health and your oral health is to quit using these products. I, as your dentist, strongly encourage you to quit. How can we get you there? What can we do? Are you interested in quitting? And then maybe point anything out you see in their radiographs, bone loss, right, etc. And refer the patient then to resources, and we're going to talk about the quit line here as we close. If they're ready to quit, we provide brief counseling, and we're going to refer them to an organization that can get them medication, telephonic counseling. Quit lines is what I'm going to talk about today. If they're not ready to quit, we're going to strongly encourage them to consider quitting and let them know that we're available to help them when they're ready to quit. I would recommend that you have all of your staff member trained. Okay, this is a Dental Board of California case, which has since been taken down, but this was a case where a dentist failed to counsel an implant patient regarding tobacco cessation, and it was alleged that they received an allegation of practicing below the standard of care, but not gross negligence. So what happened? The patient came in, they were treatment planned for implants, restorative care, periodontal therapy as well. They were not counseled about tobacco cessation. Nothing was documented. The treatment failed and the dentist was disciplined. So here's what I want you to do with the quit line. This is the North American Quit Line Consortium, which is headquartered here in Phoenix still, I believe. And you can go to the North American Quit Line and you can look up your state or territory quit line. Every state and territory, including Canada, I believe, has quit lines. This is Arizona's. It's called ashline.org. It's free to you, the healthcare provider. It's free to your patient. The very first thing, your homework is to register your dental practice with your state quit line. Then develop a template in your software for every patient, asking them about their tobacco and vaping use so that everybody is asking the same question. They're going to bring it up and they're going to fill in the information exactly as the patient answers it. And then you're going to note in that template whether or not you referred them to a quit line and what the outcome was. Okay, the quit lines are there to educate you so you can get more continuing education. Once the patient's referred in, so you've registered your practice, now you have a patient you want to refer. You can refer them right from the dental chair with a tablet or your computer. You can refer them online. Right. Quit line is going to contact your patient, set up a quit date. They're going to keep you informed. Now, I often used perio treatment and when it was relevant, whitening, because they see motivation. It's the first time their mouths have been nicotine-free, tobacco-free in years, right? Their taste is coming back. They can start seeing the improvement, all right? So ashline.org is Arizona. Every state has one. California's is called nobuts.org. Go on there again, register. You can order materials for your patients. You can put their link on your website. Take more continuing education, and then you can refer your patients right through the website as well as fax. Now, the counselors are trained in about 14 different languages or so. So depending on where you're at, you may need a particular language, which is great. Again, they're going to set up a quit date for the patient. They're going to keep you involved. All right. And these programs are highly, highly beneficial, and they're no charge to your patients. They oftentimes offer free medication as well. Okay, so again, more information, how to make a referral, how to check on the status of a referral, and register your practice. That's your homework. And document. Set up a template, you dentist, to make sure everybody's asking the same questions and completing it for every patient, not the patient that just necessarily checks off that they smoked. Every patient that walks in your door. Ask them about vaping. and let them know the concerns that you have about vaping as well. And then let them know that you're available to refer them, and you're going to refer them to the Quit line. All right, we've got some questions and comments here as we close. I had a patient who never smoked but lived with a husband who smoked in the house, and she died of lung cancer. Yep, unfortunately, that is the case. Chronic smokers must ingest 5 times more vitamin C than non-smokers. I haven't seen that, but Dr. Valentine, if you could send that to me, I'd be happy to share it once I can review that with our classes in the future. Sad thing is that even that won't get them to stop smoking. No, they need a lot of help. They need professional help. That's why we're not the professionals to really do it. We're the conduit. They have to know that they have partners in the process. But don't be disappointed, again, because they fall off the wagon here, because the problem is that it's an addiction. And long-term abstinence for many of these patients is the best hope we can have for them. Getting them on a long-term abstinence, if they have a hiccup or something along the process, and getting them back on track. What about having some of the Quit lozenges for use after extractions? So there are different things that can be done. Nicotine patches, I prefer more than the lozenges after an extraction. But if we have time, ideally getting them referred to a Quit line prior to the treatment. We don't always have that luxury, right? Might be an emergency extraction, that sort of thing. I read somewhere that tobacco smoking provides a film around the teeth, rendering them less susceptible to tooth decay. Yeah, that is not correct. That was floating around for a while, but there's no evidence to suggest that's correct. We certainly have data to show it's the other way around, but it also depends on the cigarettes, their use, the patient, etc. I had a patient last week who needed dental clearance for a joint replacement. She told me that the surgeon tests for nicotine in her blood and will not schedule the surgery until she quits smoking. And that is correct. That is a trend right now in medicine, and maybe that's what we need to think about in the future as well. Do Quit lines assist smokeless tobacco users? Yes. So Quit lines, excuse me, and thank you, Mary, for bringing that up. Quit lines can be used for vaping, for smokeless tobacco, for pregnant women, for teenagers, as well as tobacco cigarettes. 311 is also a good resource as well. What about pot smoking? So pot smoking is another 4-hour course that I'm developing. I didn't go into pot smoking here. I do discuss some of it during our vaping class. My father has COPD from 50 years smoking, always coughing. My patient got a part of her lung removed because of cancer and still smokes. And that's, again, that is an addiction, right? So not a bad habit. That is an addiction. We know that if we're driving in a car and we continue to sit on the railroad tracks, eventually we're going to get hit by a train, right? In these cases, these folks, because of the nature of nicotine and the psychoactivity, it will cause them to keep using the device, which in this case is the cigarette or the vape. So that's why they need professional help. But it's incumbent upon all of you to have a safety net in your practice and realize that a patient that's smoking a pack a day and we treatment plan, quadrant scaling, root planing that we know is going to fail, and we know it's going to fail. We have to take a good look at that practice because it can get you in trouble. So the patient has to have some sort of cessation program that they're in so that we can justify something that would otherwise be a poor guarded prognosis. All right, everyone, I am going to log out here in just a second. You are, go to the Quit line and register your practice and encourage everyone in your practice to take a course. if it's not this one, take a course through the Quitline. Now, here in Arizona, the program that I administered, we had hygienists that went out to dental practices and trained them personally, the entire practice. So everybody was there. They were on board. I have to say, we had a contest every year for those that referred the most patients to the Quitline. And the practices, excuse me, that one would get a full page write-up in Doc Magazine every year, which was great marketing for them here in the Phoenix Valley. But the practices that had all of their staff trained, their hygienists were the stars. They were the ones getting the patients referred into the Quitlines because they had the ability to converse and connect with their oral health and staining and all of those issues, right? So definitely connect with your Quitline, take the classes, get your staff on board. All right, everyone, we're going to log out now. You're going to be redirected to a screen to complete the quiz. You'll also receive a reminder email from us. And we want you to have a great weekend. If you need to take an infection control, I will be back here tomorrow morning, and it will reach max. So I think we max at 1,500. So hopefully get on board or take it next month. Thanks so much. Have a great weekend.